Hello everyone, thank you for joining today's webinar. We'll start in approximately 2 minutes just to give some time for folks to jump into the webinar as well. Thank you. Hello again, everyone. Thank you for joining us for today's webinar titled Introduction to Policy Systems and Environmental Change Approaches to Public Health. This webinar is being hosted by 3 institutions: the Asian and Pacific Islander American Health Forum, New York University Center for the Study of Asian American Health, and Hunter College in New York. My name is Pedro Arista, and I manage the STRIVE project with my colleague Catlin Rideout from CISA. I will moderate the Q&A toward the end of the presentation. Before we dive right into learning about PSE, let me mention there are STRIVE, HTACF, and REI cohort members on today's webinar. The STRIVE project is funded by the Centers for Disease Control and Prevention and has strict guidelines related to PSE activities. Given this, much of the webinar will focus on PSE related to physical activity, nutrition, and weight management. Each cohort, STRIVE, HTACF, and REI, has a different focus, but our hope is that each cohort will be incorporating elements of PSE into their work. Before I hand it off to Dr. John Chin and Ilana, I want to briefly cover some instructions on how to use GoToWebinar and ask questions. On your screen, you should be able to see the control panel on the right side of your desktop. After about 10 seconds, the control panel automatically collapses to the right side of your screen with only the Grab tab displayed. You can use the double arrows at the very top to open, close the control panel. You can use the questions panel to ask us any questions you may have. We definitely encourage folks to ask questions throughout. At the end, we'll have a question and answer period with our presenters as well as Ed Tiporn and Dr. Simona Kwan. This is a great opportunity for you to ask questions. Finally, we will be recording this webinar and it will be uploaded onto our YouTube page, www.youtube.com/APIAHF. But for those of you who would like PDF copies of today's presentation, please let us know by typing in your email address on the questions panel. I now have the opportunity to introduce our 2 fantastic presenters, Dr. John Chin and Ilana Behar. Dr. Chin is an associate professor and director of the Graduate Urban Planning Program at Hunter College, City University of New York. His research focuses on the role of community institutions in community planning and in the delivery of social and health services. He is also interested in how key community-based institutions in immigrant and minority communities shape values and norms, particularly in relation to controversial topics like HIV. John is the principal investigator of a 5-year NIH-funded study on Asian immigrant religious institutions and their potential role in HIV prevention. Our second presenter is Ilana Behar. Ilana is a research associate in the Department of Urban Affairs and Planning at Hunter College and serves as project director and coordinator for several studies. One of her main projects has been an NIH-funded study called Involvement of Immigrant Religious Organizations in HIV. It seeks to examine the potential for Chinese churches and Buddhist temples for being involved in HIV education and prevention activities. We'll begin with you, John, and then Ilana, and end with a Q&A. Thank you again.
Okay, great. Thank you, Pedro. I think I'm waiting now for my screen to come up. Okay, I think there we go. So the purpose of today's webinar is to introduce participants to policy, systems, and environmental change approaches to community health promotion, focusing on physical activity, nutrition, and obesity. We hope participants will come away with a clear understanding of how PSE approaches differ from conventional individual and group level health programs. In our webinar today, we will explore conceptual models of PSE impacts on community health, review the history of PSE approaches in public health, discuss PSE causes of community health problems, and then present model initiatives illustrating evidence-based PSE practices. We'll also take a look at a model case study of the entire PSE change planning and implementation process, and that will be followed by Q&A and discussion. So before we jump in, Pedro is going to administer a short poll just to see where everyone's at around PSE. So we're going to wait a couple minutes. You can just click on your response when it comes up.
Okay, John.
Yes. You know, I can't see the poll results on my screen. Should I just go ahead and continue?
Sure, go ahead.
Okay. Let's see. All right. So let's jump in first by talking about some of the CDC core principles. So much of the push for the PSE approach to public health has come from the Centers for Disease Control. In particular, the CDC Division of Community Health has been funding health departments and CBOs to implement PSE-related strategies over the past several years, mostly through various REACH and Community Transformation Grant, or CTG, initiatives. And through PSE approaches, they hope to maximize health impact, advance health equity, and reduce health disparities, and also to use and expand the evidence base. So in thinking about PSE change, there are two approaches to consider. The first includes interventions that impact the majority of individuals regardless of race or ethnicity in a particular geographic location. For example, creating a school district-wide policy on serving healthy snacks. The second approach includes interventions that are specifically targeted to Asian American and Native Hawaiian Pacific Islander populations. For example, working particularly with Chinese language schools to serve only healthy snacks. So the CDC is interested in maximizing the health impact of their programs. Because the PSE approach reaches more people and its effects are more sustainable, there's greater exposure, greater dosage, which maximizes the impact of the program. And we'll talk a little bit more about why that is. So PSE approaches focus on where we live, where we learn, where we work, where we play, and I could add also where we pray. There's an interest in working with religious institutions as well. So what is a policy systems and environmental change approach? PSE change approaches move away from focusing on individual behavior. They focus instead on changing policies, systems, and the physical environment to directly improve health, for example, through reducing car use for cleaner air. They also make it more automatic for individuals to make healthy choices. So, for example, providing bike lanes to encourage biking instead of driving, or eliminating unhealthy choices in school cafeterias. PSE approaches aim to make large population-wide impacts, and they're also more sustainable than time-limited health programs or events in that they continue on even after the program is over. So let's break it down a little bit. What's policy, what's systems, and what's environment, without getting too caught up in the distinctions between those definitions. They're somewhat fluid, especially between what is a policy change and what is a systems change. But very basically, a policy change is passing of laws, ordinances, resolutions, mandates, regulations, or rules. A systems change is changes made to rules within an organization to make broad impact. So for example, a policy change might be implementing a tax on unhealthy foods, and a systems change might be reviewing the school lunch menu to ensure that offerings are in line with nutritional guidelines. An environmental change is usually a change made to the physical environment. So for example, establishing bike lanes or installing sidewalks to connect residential areas with transit stops. So one way of thinking about what PSE is to look at PSE in relation to your typical, more conventional individual or group level health program. So this slide shows 3 different areas of PSE change, the school setting, the community setting, and the worksite setting. So in the school setting, a typical program or event might be to celebrate National Nutrition Month to get people to eat more healthy foods, whereas a PSE approach would be to add fruits and vegetables to the a la carte options in the schools. So you can see how the first approach is much more time limited. It depends on people coming to the program, learning and retaining some of the information, whereas the second approach, the PSE approach, it's part of people's everyday activity, and so it becomes more automatic for them to choose something that's healthy. And so in that sense, the PSE approach is more sustainable. So similar examples for the community. The typical program or event might be to host a community bike ride or parade, whereas the PSE approach might be to implement a quote-unquote complete streets policy that looks at making roads safer for biking, walking, and driving. And then at the work site, a typical program or event would be to hold health screenings for staff, and a PSE approach would be to implement a healthy vending machine policy that offers healthy snacks at affordable prices. And we're going to talk more about that at the end. Okay, so I wanted to present to you some conceptual models to think about where PSE fits into the overall realm of doing public health work. So this is going to get a little bit theoretical, but I think it's worth doing to broaden people's understanding of what PSE can do. So this model illustrates the multiple levels of influence on health and non-health outcomes, kind of moving from macro to micro. and also roughly from things that are very difficult to change to things that are a little bit easier to change. So when we think about PSE change, it's important to zoom out and look at some of the more macro factors that affect outcomes, because we can then think about where best to intervene at multiple levels. So I'm going to walk through each of these boxes. So if you look at this bottom box, the enduring structures, these are things like economic systems, religion, government, et cetera, that are very difficult to change, really embedded into our society. So examples of those might be something like free market capitalism or Judeo-Christianity from a religious perspective. Then moving from left to right, we have major global and national trends. An example of that is immigration, which really changes the makeup of our society, has a very fundamental impact. Next are state and local determinants, such as government policies and practices and markets. An example here might be, for example, the marketing of tobacco and cigarettes. So that's a market kind of determinant. And then at the government level, a cigarette tax might be considered a government level policy that affects health. And then the local living conditions are the kinds of things that are part of our everyday direct reality, our experience. And particularly relevant to PSE is in the second area here under there, which is the physical environment, housing, the density of an area, the built environment, pollution, that sort of thing. And then those have impacts on health and non-health outcomes. So I know that some of you are not, you're not required to achieve health outcomes. And so I wanted to insert kind of explanation of how this model might apply to non-health outcomes as well. So say, for example, your health outcome, starting at the far right of the model, is to achieve a living wage and housing stability. So you might start, most of our programs are going to start here in state and local determinants and local living conditions. However, you might also look at some of these enduring structures. For example, Occupy Wall Street, I believe, is trying at least to affect some of these enduring structures, such as our economic system, that may have an impact on a living wage and housing stability. So closer in, government policies and practices, such as raising the minimum wage, intervening in markets. So for example, rent control for affordable housing. These would change people's socioeconomic status and their housing situation and lead to the achievement of your non-health outcomes, which is living wage and housing stability. So let's take a look at this model now, looking at health outcomes. So say, for example, the health outcome you are aiming for is physical activity. Let's stick within these boxes here, the middle two boxes, state and local living conditions. Government policies and practices here may include zoning to allow bike lanes, design requirements for new development that require bike racks. This would change the physical environment, the built environment, reduce car use, reduce air pollution, and also make it easier to bike and walk, and that would increase physical activity and all the benefits that come from that. All right, so I want to introduce this second model. This is the health impact pyramid, and I'll talk a little bit about how it relates to the previous model. So this health impact pyramid was developed by Thomas Frieden, who's the director of the Centers for Disease Control. And part of why this model was developed was to try to move public health work towards interventions that have larger impact rather than smaller impact. So whereas the previous model that we just looked at looks at various levels of influence on health, this model looks at different levels of intervention or programs to improve health. And there's a rough correspondence between the different levels of this pyramid and the different boxes on the previous model. So let's just start at the top here, going from smallest impact to largest impact. So counseling education programs at the top end of the pyramid, then moving to clinical interventions, which has a little bit of a larger impact. Long-lasting protective interventions such as immunization has even a larger impact. then changing the context to make individuals' default decisions healthy. This is really where PSE change resides. And then finally, very fundamentally, looking at socioeconomic factors such as education, income, race, and ethnicity that have the largest impact on health outcomes. So here's the same pyramid, but now side by side with it are specific programs or interventions that relate to each level of the pyramid. So on the top end, again, with counseling and education, some examples that apply to physical activity or nutrition include dietary counseling or counseling to increase levels of physical activity. A clinical intervention for nutrition or obesity might be gastric bypass surgery. It's really hard to think about long-lasting protective interventions that apply specifically to physical activity and nutrition. The classic example, as I said before, is immunization. Currently, at least, I don't think we have a vaccine for obesity, but that would be an example of something like that. And then finally, in yellow here, these are PSE approaches in the changing the context level of the pyramid. So for example, trans fat elimination in foods, community and transit designed to promote greater physical activity, etc. And finally, the most fundamental element of the pyramid, socioeconomic factors, so that interventions there might include reducing poverty, increasing education levels, improving nutritional options for people in their neighborhoods. Okay, so I wanted to look a little bit at the historical roots of PSE change to help us understand how we got to where we are today. So many significant public health interventions of the late 19th and early 20th century were initiated in cities, because cities was where many of society's health problems were concentrated. Public health and urban planning were partners at this time. They worked hand in hand because both aimed for large-scale PSE improvements to neighborhood conditions to improve health. Their underlying rationale for their interventions was often faulty, but the outcome was often beneficial. So for example, the miasmatists believed that bad smells cause disease, and this belief may actually have delayed effective response to things like the waterborne cholera epidemic. However, their instincts led them to interventions that increased population's exposure to air, light, and sanitation in housing, and this actually had health benefits. So what happened? Why did all these problems concentrate in cities? So in the 19th century, we had the Industrial Revolution, which led to rapid urbanization. Cities were growing very fast and becoming very dense, and we didn't really know how to live together at such high densities in such high numbers. We had a lack of sewage systems, lack of clean water, lack of street cleaning, lack of pure fresh food and milk. And so you can see, for example, how chaotic and crowded the city of the time was. And here's an intersection in Chicago. To give you a little bit of a sense of what the sanitary conditions were like, there were many animals on the streets at the time. So there was one horse for every 10 to 20 residents, and daily each horse produced 20 to 25 pounds of manure and 2 quarts of urine. There were often dead animals in the streets, such as horses, goats, pigs, and cattle, overflowing privies in back alleys, and unemptied garbage boxes. And that created conditions in the streets that may have looked like this at the time. And there was also a lack of public response. Much of the response was really led by private markets, and so the quality of housing was really dictated by markets and landlords, and basically they built and maintained the quality of housing that people could afford. That, coupled with the lack of zoning, led to a sometimes chaotic built environment. So you could see, for example, houses being built where you would never think to build them these days. This slide, for example, shows housing built into what would normally be a courtyard in an urban environment. So the effect of all of this was increasing death and disease rates and the flattening or diminishing of life expectancy. So to give you a sense of what this might have felt like, in 1863, 1 of every 44 persons died in Boston and Philadelphia, and 1 of every 36 persons died in New York City that year. Very high rate of death. So in the late 1800s, there was a public outcry about these situations. This was fueled somewhat by the seminal works. You might have heard of Jacob Riis's How the Other Half Lives, which is a classic example of sort of photojournalism at that time. And here are some of his photos documenting the very poor living conditions of the time. So you can see the very crowded housing conditions. So because of this renewed awareness of the urban living conditions, there was a concerted public response that really took the form of PSE change. So there were new tenement laws regulating access to fresh air and light. There were new systems set up for connecting housing to new water and sewer lines, replacing wells and privies. Nuisance laws required property owners to keep properties clean. And new laws required refrigeration of food and created milk inspection programs and required purification of milk. So here is a classic example of the impact of a PSE change on the built environment. This is a bird's eye view of your typical New York City tenement. And you can see when the tenements are stacked up piece by piece that because of the way they're designed, there's always a courtyard in the center that creates some access to light and air for the residents. And here is a photo of that from the roof. You can see the air shaft down the middle that brings in light and air. So moving into the 20th century, so we have improved housing, reductions in urban density through suburbanization, better nutrition, and improved transportation options, which meant fewer horses and feedlots. And this led to tremendous reductions in morbidity and mortality. So you can see here, this is a graphic of deaths per 1,000 population per year from the New York City Department of Health. These are the vital statistics. And you can see starting in 1800 at the far left, there were about 30 deaths per 1,000 population per year. But this spiked up to 50 when there were epidemics. Here's the cholera epidemic of 1832, a few other epidemics. But then you see a steady decline towards the end of the 1900s to where we are now, which is less than 10 per 1,000 population per year. So we had a dramatic increase in life expectancy. The largest jump occurred in the first half of the 20th century, and that paralleled the reduction in infectious disease. Life expectancy jumped almost 30 years, from 50 years in 1900 to almost 80 years today. So because we were so successful in conquering infectious diseases such as cholera, public health became much more further medicalized. Public confidence in science increased a lot, and so PSE approaches were considered somewhat non-medical or non-scientific, and so they kind of took a back seat at this time. So with the threat of infectious diseases largely contained, other health problems became predominant. So there were increases in chronic disease such as asthma and diabetes, and also diseases associated with older age, including cancer. So you can see here, for example, in 1880, the percentage of deaths attributed to infectious disease was 57%, whereas now the percentage attributed to infectious disease is only 9%, but the percentage of deaths attributed to chronic disease is now 75%. And these are statistics from New York City, but it's very similar across the country. So where are we today with PSE? What are current conditions? It's important to know what the current PSE conditions are because we want to know how those problems were created and what the problem is so that we can fix it. The physical environment is at the root of some chronic diseases related to the lack of physical activity. And the case of sprawl is a classic example of how PSE conditions can cause health problems and how we can use PSE change to address health problems. I think it's also an example of a kind of area that public health has often ignored. So ironically, the origins of suburban sprawl, or urban sprawl even, resulted from PSE changes aiming for health benefits. So as I said before, there were perceived health benefits of air and light. People like the parks planners, the Garden City movement, the decentrists, all aimed for spreading people out. So there was a philosophical underpinning to that. That was supported by policies that promoted quote-unquote slum clearance and urban renewal that raised urban neighborhoods and then moved people out into the suburbs. Other policies that made mortgages available, more so for white families through the Federal Housing Administration and the GI Bill. We also had from the markets the promotion of car use by the auto industry. We also had policies that subsidized highway construction that allowed people to live far away from the center of the city. We also had the enduring structures, the role of culture, so the idea of the American dream being home and car ownership. So what are PSE characteristics of sprawl? Primarily single-use residential districts, otherwise known as bedroom communities, places where people just live but don't work or shop. Also auto dependence. So the health consequences of sprawl derive from increased auto use and its associated dangers, so accidents and air pollution. Also reliance on cars and having everything so spread out means that there's a reduction in physical activity. People aren't walking, they're basically driving. So as a result, increased obesity and overweight, and also increased risk for a variety of conditions that are related to lack of physical activity and obesity. There's also some consequences for nutrition from sprawl. So urban population loss meant that poverty was concentrated in central cities. This led to food deserts in some poor communities in urban areas. Food deserts is a condition where there's a lack of healthy food outlets in an area. There has also been increases in crime in certain areas as a result of sprawl and population loss. And that leads to a fear of being outside, and that leads to a reduction in physical activity. So recognizing that sprawl and other physical conditions create health problems, there's been a renewed interest in systems-level change and the impact of the built environment on health. And a lot of people call this the new public health, but really it's a return to the old public health. Part of this interest was fueled by new research that shows that there are benefits of moderate levels of physical activity. You don't have to hit the gym intensely for 2 hours a day, 5 days a week to get health benefits. So with this recognition, the idea became that we should try to get people to engage in moderate levels of physical activity in their daily routines. So that's called utilitarian physical activity, which is really walking or biking to run errands or to get to work, versus having to make a special trip to the gym. So a non-sprawled, dense environment with mixed uses meaning there's more than just residences there. There are workplaces, retail, shops, etc. Coupling that with mass transit so you don't have to get into your car even if some of these places are far away from you leads to more physical activity. People have places to walk and to bike to in mixed-use, high-density areas, and they don't have to get into their cars to get there. An article in New York Magazine talked about New York City as kind of a daily gym for people, where every city block doubles as a race walking track. I'm quoting here, every subway station a Stairmaster, and seen this way, the whole city looks like a massive exercise machine dedicated to improving our health while we run our errands. So a mixed-use environment plus mass transit leads to utilitarian physical activity, and physical activity becomes convenient and easy to sustain. So I want to recap that whole story by just running us through that conceptual model, particularly to look at the issue of sprawl and physical inactivity. So this first slide looks at the multiple influences on physical inactivity. So if you start at the bottom, the enduring structures, the American dream, home ownership, and car culture. Major global and national trends are highway building, auto industry lobbying, real estate industry lobbying, mortgage subsidies, and also telecommunications, which has allowed people to spread out a bit. State and local determinants include slum clearance policies, which led to the destruction of mixed-use neighborhoods, and also in the suburbs, at least, single-use zoning that allow for bedroom communities. So this leads to local living conditions that include suburban sprawl, single-use neighborhoods, car dependency, and population loss, which results in concentrated poverty and increased crime. And all of this leads to a decrease in physical activity, so physical inactivity and all the negative health impacts of that. So where are the intervention points in that? So we're going to review that same diagram, but now look at intervention points. So as I mentioned, probably most of the PSE interventions are going to be focused here at the state and local determinants and the local living conditions. So the state and local determinant interventions might include neighborhood development and revitalization programs, mixed-use zoning, transit-oriented development that connect people to transit in an easy manner, complete streets that try to make streets safe for bikes and pedestrians, policies that disincentivize car use, such as gas taxes and tolls, policies that incentivize transit use, such as tax credits. These lead to mixed-use, denser, transit-friendly neighborhoods, a decrease in car dependency, and therefore an increase in walking and bicycling, which then leads to an increase in physical activity and all the health benefits that go with that. Okay, so we've sort of covered the history, covered the theory, covered some conceptual models. Now we want to talk to you about the concrete approach to planning for PSE change in your community. All right, so the building blocks of PSE change. There are a variety of tools and models to plan for PSE change and implement PSE strategies, and they need to be tailored to match the characteristics of your population. So for a lot of us, we're talking about largely immigrant populations, Asian American, Native Hawaiian, and Pacific Islander populations. So the building blocks include coalition building, conducting a health assessment and policy scan, developing a community action plan, and then implementing evidence-based interventions that really should be focused on high impact and population-wide reach. So a very comprehensive tool for this work is the CDC's Community Health Assessment and Group Evaluation, or the Change Action Guide. This is going to actually be covered in depth in the meeting in Washington, D.C. next week, so I'm just going to introduce you to the fact that it exists and also just to outline the basic steps. So the steps are to assemble the community team, develop a team strategy, review all 5 change sectors, which includes the community at large, community-based organizations, the healthcare sector, the school sector, and the workplace sector. Then gather and review data, build the community action plan, and conduct evaluation. Just so you know, the review of the change sectors in this in this action guide, the tools that they provide are very comprehensive, very in-depth, so it's something you might want to take a look at even before the meeting in Washington. All right, so we want to talk about now specific evidence-based PSE change strategies. So Ilana is now going to talk to you about some approaches to PSE change and then also present a case study of a PSE change planning process. So Ilana.
Hi, everyone. Okay, I'm just I just need to, my screen changed a little bit. Okay, great. So I want to encourage everybody to ask questions. And in order to ask questions, feel free to use the Grab tab display to send your questions. And I notice, okay. So what are evidence-based PSE strategies? Okay, I'm sorry, I'm having a little trouble with my screen. Okay, what are evidence-based PSE strategies? Evidence-based strategies have direct, high-quality empirical evidence that demonstrates their effectiveness in achieving well-defined health outcomes. So these are strategies that research has shown to be effective. Now I'm going to give you an overview of a selection of PSE strategies. I'm not going to spend a lot of time on these next few slides. This is just to give you an overview and to show you that many strategies are available. We've separated them into 4 different categories. The first group are about land use and changing land use to improve public health. The second set of examples in this selection are about distribution and access to food. The third is how schools can be modified to improve public health. And the fourth are modifications that can be implemented in the workplace. So looking at the land use examples, I'll just bring your attention to something that can be done, for example, with bicycle route signs, the second example here, second down. In this approach, signs are used to show cyclists where bike routes are, scenic paths they may want to explore, and safe routes for them. Clearly established route signs promote bicycle transportation and, in turn, promote physical activity. This can also encourage new and visiting cyclists to come and visit communities, which can also be a benefit for communities. So looking at access to and distribution of food, here a selection of strategies addressing that issue. One example I'll just draw your attention to is our vending machines. Vending machines traditionally offer unhealthy food choices such as candy bars and potato chips. So one way to use PSE change to improve nutritional health in this venue is for parks, schools, and workplaces to insist that vendors provide healthier food in the machines. How can they insist on this? A specific strategy for this is to state that this is a requirement in the contract with a vending machine company, or that this is a condition in the condition for the contract to be renewed. Okay, some more examples of strategies for food, and now. Here we have a selection of strategies for how to improve public health using schools. And by the way, again, as Pedro mentioned at the beginning, you can feel free to ask for a copy of this PowerPoint, and then you can see all these examples in detail. And we also have links to a lot of resources you can use in this presentation. So feel free to ask for one, and again, feel free to ask questions as well if anything doesn't make sense using the Grab tab. So looking at schools, there's a variety of strategies that can be used here. We'll just look at the first one briefly, school citing policies. This is when school districts and municipalities can ensure that new schools are centrally located within the communities they serve and are therefore bikeable and walkable for students. Other policies that can be established through this strategy are, for example, setting maximum acreage standards for new schools being built, or requiring that health impact assessments be performed and create school travel plans in conjunction with that. So now, a few strategies. Here are some examples of a few strategies that can be used in the workplace as well. One nice approach is workplace stairwell modification. That's an approach that makes stairwells very appealing for people to use as an alternative to use alternative for using elevators. So a few ways this can be done are, for example, putting carpeting in stairways, putting nice lighting, having music in the stairways, or inspirational signs, and importantly, making stairwells safe for people to use. So that's a great way, for example, as John was explaining, not setting you don't need to set aside time to go to the gym. Just in your daily routine, people can improve their health that way. So now we're going to look at two strategies in depth in a little more detail, and then after that we're going to focus on a case study of a community who's successfully been using PSE strategies to improve their community's health. So the first example that we'll look at in more detail is going to look at physical activity, an example addressing physical activity, and the second is going to be addressing nutrition and decreasing obesity. So this first example looks at zoning, development, and land use policies. So the goal of this strategy is to encourage municipalities to require that new property developments include easy access to active transportation options, such as walking, biking, and transit. How can they do this? Examples of enhancing this easy access are, for example, requiring that new housing developments provide safe, secure parking for bicycles, bike racks, the same way that many places have automobile parking. Another way is by requiring that new retail developments include pedestrian facilities like sidewalks connecting storefronts to each other and to the public right-of-way so visitors can access them on foot. A third way is by requiring that new industrial developments include locker and shower facilities as a way to encourage active transportation, walking and biking and running. So as John mentioned earlier, an important building block for a PSE change strategy, one of the first building blocks, is the formation of a coalition. So if using this particular approach, one could think of the following people to be assembled in the coalition, or perhaps people that one would need to consult with, or people that one would need their buy-in for this strategy to be implemented. So some examples of people who could fit these categories are the mayor or city manager, city council members, business community representatives, or other interested community agencies. If you're interested in this approach in particular, we've compiled some evidence-based background literature that's available showing the effectiveness of this strategy. So here are some of those articles along with the links to them, and here's a toolkit example as well. So the next example we'd like to look at of a strategy has to do with improving nutrition, decreasing obesity, and it's the approach of sustainable food systems. So sustainable food systems help promote community health by providing increased access to fresh foods. How does it do that? By, for example, modifying zoning regulations to encourage supermarkets being built in the food deserts that John was talking about, or farmers markets, choosing vacant lots to transform into garden space. Other methods of encouraging increased access to fresh foods in communities can also include providing subsidies, marketing, and distribution assistance to small grocery stores to support the sale of fresh fruits and vegetables, or creating buying clubs and cooperatives to leverage the buying power of groups. So again, who should be involved as a part of the coalition or as a consultant, or whose buy-in might a community need to implement this strategy? The mayor or city manager, city council members, municipal departments related to planning and zoning, retail licensing and health, other interested community groups, or local business associations. And again, here we have some articles of evidence-based background literature supporting this approach and a toolkit example for you. So next, I'd like to talk about a case study to walk you through the whole process of PSE change planning and implementation. So Rancho Cucamonga, I'm going to refer to Rancho Cucamonga, California as RC, is a great example of a community that's used PSE tools to implement changes in their community and improve public health. So a little background about this area. It's situated 40 miles east of LA. RC was a small agricultural community that experienced rapid growth. What used to be vineyards and citrus groves are now sprawling housing and retail development. Unhealthy food outlets were common and frequented by many. This created the perfect storm for obesity and health-related problems. In 2008, the community started an initiative called Healthy RC, focusing on improving the health and quality of life of RC and focusing especially on Southwest RC, a predominantly Latino community with higher rates of poverty, deteriorated housing stock, and few neighborhood amenities. It aims to, quote, further policies and programs that promote healthy minds, healthy bodies, and a healthy earth, making active living and healthy eating the easy choice. So this case study, by looking at this case study, we hope to illustrate the role of the following steps in developing and implementing PSE change models: coalition building, community health assessment and policy scan, developing a community health action plan to implement the PSE change intervention, and then a program evaluation. So the first step is coalition building. In RC, there was a lot of enthusiasm for this initiative, as can be seen in this quote from Project Director James Troyer. This is the right time for our community to take on this project and succeed. We've got the right partners in place, and we have the political will and the support of our community, including the City Council, the school district, and the health department. And other partners are below. So the next step is the community health assessment. Here you'll notice a nice list of community health assessment tools. These are the tools that RC used to assess their community. And you can go on their website, which is listed below, to find out more about these tools. So what were the findings of this community health assessment? There were two groups of findings. First, the health of the residents, and second, the availability of fresh food and active transportation or exercise options in the community. How available were they? So first, we'll look at the health of the residents, and second, we'll look at the availability of fresh food and active transportation options. So looking at the health of the residents, RC is located in San Bernardino County. This county has the 4th highest rate of obesity in the U.S. The county had the highest death rate from heart disease, the 9th highest death rate from diabetes. 2 out of every 3 residents were considered obese or overweight, and 3 out of every 4 children did not meet fitness standards. Looking at the availability of fresh food and active transportation or exercise options, they found that there was a lack of grocery stores selling fresh produce, which meant that residents had to go out of the community to procure healthy food. Within the community, there were 6 times as many unhealthy food retail outlets as healthy ones. Many residents were limited to public transportation, which meant that members could only buy as much food as they could carry on a bus. The community contained streets with no curbs, no bike lanes, few sidewalks, and only 1 local park. Last, a high level of crime and gang activity often discouraged residents from exercising outside and children from playing there. A policy scan was conducted to see which local land use policies could be working as obstacles to improving public health and which promoted it. So the findings included that zoning actually prohibited the construction of outlets offering fresh food options to specific communities. The criteria for products sold at farmers markets were more complex than necessary, and farmers markets were hindered by temporary use permit requirements. So using the policy scan and the community health assessment, RC developed a community action plan. The policy scan formed the basis for a development code amendment, an ordinance that passed the following measures. They made it easier to establish farmers markets, to build more walking paths, bike trails, parks, and sidewalks, and to modify policies to increase the safety of residents when spending time outside and using active transportation options. Furthermore, the community action plan included land modifications and changes to the distribution of and access to fresh food in the community. So land use modifications included extending a 21-mile multi-use path on the site of an old rail line in RC called the Pacific Electric Trail. They also constructed a bike trail, created joint use agreements to make school facilities available beyond school hours for the purposes of exercise and other activities. And then modifications to the distribution of and access to fresh food included advocating increased healthy food options in schools and child care settings, community gardens, fresh food outlets, and adjusting zoning regulations to allow edible front yards, meaning the use of land to grow food. Last, a program evaluation is important to conduct to, again, just like the evidence-based literature that establishes the success of a strategy, when implementing a strategy, it's important to look at the evidence to see how successful it is and what modifications need to be made. So using RC as an example and their evaluation of the farmers markets as an example, this is how they conducted a program evaluation. They included resident focus groups, interactive customer surveys, interviews with market managers and farmers to collect data. They noted, too, that since the beginning of this program, 2 farmers markets were established in the city, making a total of 3. Those markets experienced an increase in sales and increased in Southwest Cucamonga customers. So early findings showed that, a quote from the project manager, that people are very receptive to the farmers markets and they're happy about it. Okay, so now I'm going to pass this to John so he can continue with the summary and points to conclude with.
Okay, thank you, Ilana. So just to summarize briefly before we start our discussion, PSE change initiatives are an important part of the origins of public health work. PSE change programs of the past addressed devastating infectious disease epidemics, but they actually may have contributed to today's chronic disease problems, for example, by the creation of sprawl. So today's PSE change programs need to address the consequences of old age and also the conquering of infectious disease and also the consequences of the lack of physical activity by looking at chronic disease. So the benefits of PSE change approaches are that these change systems and environments to make it easy or automatic for individuals to make healthy choices and also create benefits that continue on because they are built into systems and the physical environment, and so continue on long after the work went in to make them. So just to kind of recap, I wanted to reintroduce this slide comparing programs, events versus PSE change. So just very briefly, we can see again that a program or event is kind of a one-time education or screening program, for example. It ends when it's over and the benefits don't necessarily carry on, whereas a PSE change is something that's built into a system or in a physical environment, and it's something that people encounter every day of their lives as they're going about their usual business and allows them to make healthy choices. So with that, I will turn it back to Pedro, who is going to conduct another short poll as we move into our discussion and Q&A.
Thank you, John. And I want to just acknowledge our first polling question. The first polling question that we started with the webinar was, what is your level of experience in using policy, systems, and environmental change approaches? And overwhelmingly, people noted that over 56% noted that they identified as being a rookie, which is they're still in training. 28% identified themselves as being a newbie. What am I doing? And a few folks, 16% of you, identified yourself as a ranger. I can hold my own. So thank you for answering the first polling question. And we're going to move into 3 polling questions. Again, this is a good opportunity for folks to submit questions if you have questions about the presentation and also how it may relate to your proposed scope of work. We'll move into our next polling question. Polling question is, which example below is not an example of a PSE approach? You have about 15 seconds to answer. And you can just click on your icon, your answer. Okay. And 97% of folks identify that conducting a hepatitis B screenings is not an example of a PSE approach. John, Ilana, any thoughts?
I think that's wonderful. So at least part of our message was delivered clearly, so that's great. I'm glad people got it.
Do you just want to briefly describe why that's not, again, considered a PSE approach?
Sure. So the conducting a hepatitis B screening, it actually has long-lasting benefits in the sense that if people know their status, they can move into treatment or receive vaccination. However, it's a one-time event that requires the person actually to make a special effort to get screened. It's not part of everyday choices that a person makes.
Thank you. Moving on to our next polling question is, which example below is not an example of a PSE approach? You have about 15 seconds to answer, and you can just directly click on your answer. Okay. And 97% of participants identified celebrating American Diabetes Alert Day is not an example of a PSE approach. However, about 3% identified that implementing a vending machine policy to offer healthy snacks is a PSE approach. Any thoughts, John or Ilana?
Sure. So an American Diabetes Alert Day is an educational program. It relies on people getting a message, and it relies on them understanding the message and then acting on the message. So for example, perhaps there's a message about reducing sugar intake or getting screened for diabetes, but that requires a concerted behavior change and understanding of the information, so we wouldn't consider that a PSE approach. The vending machine policy, however, it's implemented as it's implemented systemically. So if you have a policy that applies to all schools, workplaces, tourist areas, then you make sure that those healthy snacks are available to everybody who encounters those vending machines. Again, it's part of their everyday activity, and if the healthy food choices are there, it's much easier for them to choose it.
Thank you, John. Our last polling question is, how confident do you feel now at the conclusion of this webinar in your ability to use a PSE approach? You have about 15 seconds to answer. Okay. We have respondents, a good number, a significant number of respondents answered, and 53% of the sample agree that they feel very confident in after the conclusion of the webinar in their ability to use a PSE approach, and 43% mentioned still feeling somewhat confident, and 5% a little bit confident. And as John mentioned, at the meeting in Washington, D.C., we'll have some space, some time carved out during the meeting for us to sort of have more discussion around PSE as well. Any thoughts, John or Ilana?
I would just insert that I understand why people may be feeling not fully confident in implementing PSE change approaches. They can actually get fairly complicated if you've never worked in that area before. Even if you understand the basic concept, you still have to think about how do you actually go about instrumentalizing some of these changes. How do you get a policy change implemented? Who do you have to work with? What agencies and venues do you have to work through? So those are all things that can take some time to work out.
Thank you, John. Many of you have been sending your emails to receive copies of the PowerPoint presentation. I will make sure soon after the conclusion of today's webinar to send you a copy of the presentations, as well as the direct link via YouTube that you can access the recording of the presentation. We do have a couple questions from our participants. The first question is, how long did it take for the Rancho community to get to make the PSE change in that particular community?
Well, from what I've read, they started in 2008 and until the present, so it looks like it's been about 4 years. Yeah.
Thank you. Next question is, can you provide a real-life example of PSE change that was spearheaded by a local coalition or organization or advocates that reach specifically AA and or NHPIs?
That's a good question. There's actually an example here in New York City where people, I think this was the Asian American Federation. They worked with a bunch of organizations to implement nutrition programs that would help people make healthier food choices through, I guess, more increased access to farmers markets. I don't know, maybe Simona, if you have more information on that program.
Hi, everyone. This is Ed Tephorn, Vice President for Community Strategies at the Health Forum. And so just also wanted to add in response to the questions, I think that's really part of the opportunity here, not just for the REACH Strive cohort of subrecipients, but also for the HTACF and the REI grantees, is that while there's been a lot of efforts around policy systems and environment improvement that's been led by a health department or led by other communities, I think that the literature out there around what works in Asian American, Native Hawaiian, Pacific Islander communities is still to be developed. And so part of the opportunity that we collectively have is to really test out how can we adapt some of these experiences that have been led by other communities to improve the health of Asian American, Native Hawaiian, Pacific Islanders.
Thank you, Ed. I also have, as part of our panelists or folks who can answer questions, we also have Catlin Rideout, our colleague over at CISA, as well as John and Ilana and Ed Tephorn. The next question is, what are examples or case studies of PSE changes, approaches, that were accomplished in shorter time frames? Maybe John or Ilana?
Again, a very good question. I mean, most of the programs that I'm aware of have taken place over, I suppose, a longer period of time. Those are programs that I'm much more familiar with. However, if you think about the range of options that are available to you, it's easy to imagine that some of these programs could be implemented in a relatively short period of time. So, for example, looking at school lunch menus, evaluating the food offerings and making change to those, especially if you live in a smaller community, could happen within one cycle of a legislative body in your area. So that's an example of something that could happen pretty fast. Things like the workplace stairwell modification could also happen relatively quickly, especially in a smaller community.
And this is Ed again. I think that these questions really are addressing some of the elephants in the room, if you will, where for the REACH cohort, your funding is only guaranteed through September of 2013. So that's from today, a 7-month period. For the Health Through Action for Children and Families cohort, your funding is only through December of 2013, so that's only a 9 to 10-month window. And so we definitely recognize that often policy systems and environmental improvements take time for movement along the dial to occur, and unfortunately we don't have the luxury of time. So I think that that's where it's especially important as you go into next week's DC meeting to listen and hear and absorb what the building blocks related to policy systems environment change are. But then there is an opportunity in the weeks that follow to have a dialogue and conversation with your assigned project officer, either from Health Forum staff or from CISA staff, to think about the original proposals that you submitted, how they might need to be tweaked or adapted given the limited time frames, and really what's most achievable in terms of high-impact population-wide improvements. We also recognize that many of you have not received your formal notices of award yet, and we definitely apologize for the delay in getting those out, but part of the delay does have to do with the need for us to have the organizations that we've selected through the RFP process to be officially vetted and approved by CDC, and we are actually still waiting for that final approval from CDC. So I definitely appreciate everyone's flexibility too in terms of going ahead and committing to attending next week's meeting in DC. We do hope that ultimately everyone that we've invited to DC next week will be formally approved to be one of our cohorts, either for the CDC REACH or the HTACF or for the REI cohorts.
Thank you. Simona, did you have additional thoughts or any feedback?
Can you hear me?
Yes.
Yeah. Okay. So I was just going to add it in that there is recognition that this type of PSE approach does take time, and there have been examples of groups that have worked on things, and because of timing, policies have come up and everything has worked at the same time, and there has been short time frames for some of this work to happen. But for groups that are starting from scratch, yes, it does take, it involves over making relationships, and it really depends on the context. So in terms of the STRIVE grantees, I think one of the things that we tried to stress in the RFP and in looking at the proposals was that there was a ground base already for work to be completed within the time frame of the grants, and understanding that contextual factors, economics, policy, political environment changes, and it can help or it can hinder the process and progress of some of these PSE approaches. But in terms of a movement, yes, moving the dial forward and trying to get some of these policies or systems or environmental level changes in place does take time.
Could I just add one thing, Pedro, which
Sure.
is that one way of implementing things quickly is to build on initiatives that are already in place.
Mm-hmm.
So, for example, in New York City, there's a commitment on the part of the Department of Transportation to implement a certain number of new bike lanes every year. And so perhaps a community could build on something like that to advocate for a new bike lane in a certain neighborhood or population.
Thank you, John and Simona. We have, it's about 1:17. We have about 13 minutes before the end of the webinar. I encourage you, if you have additional questions, to keep sending them our way. We have another question looking at guidelines. And how do you overcome federal guidelines and regulations that become detrimental to implementing PSE changes approaches?
Hi everyone, this is Ada again. So definitely for our STRIVE subrecipients, there are specific regulations that both the Health Forum and CISA, as the co-lead organizations, as well as any subrecipients that we fund, need to follow in terms of not using federal dollars to participate in either grassroots lobbying or direct lobbying. There's also actually additional language that's even more specific from CDC that talks about prohibiting the use of these resources for advocacy. And so we recognize that when we talk about policy systems and environment change, a lot of times what that really relates to is working with local decision-making individuals or bodies around specific ordinances or pieces of legislation. That is something that we are hoping to do a follow-up webinar for everyone on, not just for the STRIVE grantees, but also I think it's important for the HTACF and REI grantees to understand the difference between advocacy, direct lobbying, and grassroots lobbying. And so if folks can maybe hold on to that question, and we promise that we will provide additional guidance and clarity in terms of what's allowable and unallowable in terms of activities related to your specific projects.
Thank you, Ed. Currently, we've answered all the questions for this webinar. If you do have additional questions in the future, please go ahead and send them our way. You can do that by actually reaching Dr. John Chin directly. His email is on the first slide, or Ilana, or you can send them directly to myself at parista@apiahf.org. That's again parista, A-R-I-S-T-A, at apiahf.org. We will be sending out the PowerPoint as well as the recording to all those who registered. And we'd like to, again, thank you very much for participating and joining in today's webinar. And we look forward to seeing many of you at next week's meetings. Thank you again, and wishing everyone a great day.
And we'll also be sending out an evaluation form at the end of the week, and we do ask that everyone who participates in the webinar take the moment to fill out the evaluation form and give us feedback on what was helpful about the webinar that you participated in today, what you would like for us to consider as we plan future webinars to make sure that the topics that we're covering, the way that we're presenting the topics, ultimately that we're providing you with the information and support that you need to be as successful as possible. So we appreciate your honest and candid feedback in the evaluations.
Thank you.